Welcome to the Federal Focus, Health IT, the first in a series of programs that brings government and industry together to explore how agencies connect the dots between modernization and measurable impact. I'm FedGov Today's Francis Rose. New policies and regulations and new demands on the healthcare workforce are two of the major issues federal health IT professionals say will impact how they do their jobs. Those professionals say they're working with frontline healthcare providers on technologies that will improve operational efficiency, tackle chronic disease, and reduce waste, fraud, and abuse. In this episode of the Federal Focus, recorded at ACT-IAC's Health Innovation Summit, you'll learn how advances in telehealth, generative AI, electronic health records, and more will help organizations move the needle on caring for patients. First, Maximus CEO Bruce Caswell. He describes the biggest forces reshaping how agencies deliver care and measure value. Bruce, welcome. Thanks for joining me. What are the biggest factors that are kind of reshaping federal healthcare provision right now?
Well, there are a number of factors, and I would say there are some that are macro in nature and some that are more isolated to federal agencies and delivery systems. Obviously, the biggest macro factor is that the cost of healthcare continues to be a big challenge for this country and the delivery systems where we provide healthcare to hundreds of millions of folks, and that ends up permeating policy decisions. And so the first area I would focus on is the importance of ever-changing policy in healthcare delivery, whether they're alternate payment models that are being constructed or ways that we focus our healthcare system presently on trying to identify areas of fraud and abuse and so forth. So policy and its implications on healthcare delivery, first big area. Second area, of course, I have to say is citizen access and access to services. And an area that we've been focused on, and many are the consequences of the rural healthcare funding that is about to be put out to the states, and how that will affect the ability for rural systems to support the demand that we see, which brings us to probably the third area, obviously, which is technology. One of the biggest implications perhaps from the pandemic period is the importance of telehealth and telemedicine in delivering healthcare services. Payment systems have to keep up with that for sure. But across the country, and certainly as federal agencies look through their lens at delivering and paying for healthcare services, those three areas are of great consideration.
It strikes me that the healthcare sector is similar to other IT sectors in the federal government in that the systems have to continue to run while they're being modernized. What's the implication of that for those first two things that you talked about when operationally you can't put a system on hold for a while?
Yeah, that's a great question. And one of the ways that we like to think about it is just as you've said, it's kind of like changing the engine in the plane while you're flying it. There's certainly some risk involved, but there are techniques and there are approaches that can be taken that can help you incrementally modernize systems while maintaining their ability to serve citizens. And as I think about it, I'm reminded, for example, that it's really only a small percentage of federal systems that have been migrated to the cloud. So as many agencies consider cloud migration and cloud enablement as a strategy, they have to then think about the architectures that they're using to do that. They have to think about, certainly in the healthcare area, containerization and protection of data. And then if you go a little bit further on that path, you're thinking about, well, okay, if I'm going to be developing and modernizing those systems, how do I do it in a way where I'm very, very conscious of cybersecurity requirements and the requirement, for example, to ensure that I'm having adequate encryption through the entire journey of that data as it's in the system. So the approach that I would ultimately advocate, that we've advocated with our customers, is to take an incrementalist approach that begins with some of the areas of greatest pain that you're seeing. And from our perspective, which may be a bit biased, given that we serve about 110 million Americans, we focus on the customer experience. The nice thing is that the customer experience can be modified and improved while you are flying that plane. And examples, which we'll, I'm sure, get into, are everything from contact center operations to the types of digital portals and so forth that individuals use to interact with the healthcare system. So an incrementalist approach that's mindful of the mission of the organization, and most importantly, the importance of data security and cybersecurity are some paramount thoughts in that area.
I do want to touch on the idea of using IT to help improve the customer experience in a moment. But before we get too far afield, is there an opportunity there too for organizations as they're considering those cloud transitions to think about business process modernization at the same time?
Yeah, absolutely. It's probably a bit of a worn out phrase, but paving the cow path is not a great strategy.
Right.
And so, and in fact, if I might, we internally, as we've looked at how we can apply technology to modernize some of our own business processes, consistently kind of run into the momentum that is created by established processes and the pockets of resistance that you can encounter where people say, well, wait a minute, this is the way we've always done it. This is the only way to do it. Well, rethinking those business processes and figuring out how to accomplish what can be very complex orchestrations in a simplified manner is critical. And one of the ways we think about that as a company is always putting the end user or the beneficiary or the recipient of the service first. And working back, and this is not a new concept, whether it was user-centered design or something else, but working backwards from that citizen experience and saying, what's going to make that the very best possible experience, and how do we take unnecessary steps out of that business process and re-engineer it in a way that can deliver the experience in a highly effective, accountable, high-quality manner is really how we would go about approaching that.
All right, what's the big potential now, and what is the big potential coming down the road for people to use IT to succeed in all the areas that we've talked about today?
Wow. Huge question, but I would begin by saying, number one, we need to be able to, again, our perspective is from the citizen standpoint. So we want to be able to enable individuals to use IT on their terms and not try to drive, for example, transactions that are overly complex to a cell phone, as a very simple example. But we also need to constantly be rethinking maybe some of our predisposed views of how people want to use and interact with technology. And to unbundle that a little bit more, obviously there are generational differences. And as we have, more and more people age into Medicare over time, as an example, more and more, a greater percentage of those individuals are going to be more comfortable with different types of devices to interact with government, whether it's, a cell phone or even moving on to use some of the AI capabilities that are available. As I think of a concrete example that always brings this home for me, I think about the way for a major Medicaid program that we operate, we were able to implement a mobile application that enables individuals to submit all the documentation they need to be determined eligible for Medicaid and to re-enroll when that time comes through their mobile phone. So the concept of a digital divide that existed for many years, we've seen that divide close quite dramatically. And in that program now, only 1% of the applications for the program come in on paper. And so it's possible to make that happen, and you have to do it in a very thoughtful way that, again, meets people where they are.
Bruce, it's great to talk to you today. Thanks very much for your time.
Thank you.
Maximus CEO Bruce Caswell. Coming next, the mindset shift toward patient-centered care. The federal focus, Health IT, continues in a moment.
Innovation doesn't wait, and neither do we. At Maximus, we solve problems, streamlining operations, delivering solutions at speed and scale that drive measurable results. From strategy to execution, we simplify complexity, building trust through expertise and innovative technology. Every service, every time. Efficient government delivered. We don't follow innovation, we drive it. Maximus.
Welcome back to the Federal Focus, Health IT, presented by Maximus. Health Resources and Services Administrator Tom Engels tells FedGov today his agency's focused on improving access, restoring trust, and delivering better outcomes to some of the nation's most vulnerable populations. HRSA's acting CIO tells FedGov today's George Jackson data serves as the connective tissue in that shift toward patient-centered care.
Srinivas, I want to start big picture with you. Like before the cameras got rolling, we were talking a little bit about like this groundswell, this major trend in healthcare, in health IT, in a move more toward a term called patient-centered care. could you, like from HRSA's perspective, explain that for me? What does patient-centered care mean, and how do you sort of begin to effectuate that through better use of information technology, sir? Welcome.
Thank you. So from HRSA is basically a grant-making organization. So we, when we give out grants and provide healthcare, we provide to millions of people. I'll take an example of Bureau of Primary Healthcare, for example, right? Bureau of Primary Healthcare provides services to about 32 million individuals in the U.S. That's 1 in 11 Americans. And it also, basically they have over 100 million visits. So when you have, if you're trying to do some, make a dent into chronic diseases and things like that, you kind of need longitudinal data and you need patient-specific data. So when you try, in the past, what HRSA has done was they avoided collecting data about individuals. What they would do is they would collect aggregated data. So you would get a table full of, okay, we saw 5 million these type of people, 6 million of these type of, you'd get numbers like that. But those numbers, when they get averaged, they're not actionable. So a few years ago, we started looking at collecting patient-level data, but in a de-identified form. So you basically, because you want to protect PHI, and there is a safe harbor PHI type things you can do up front. There are about 18 things you can do to any data that you collect. So when you collect it, it's already de-identified. There's no way to make it back to the source, how you mask the zip code, how you don't collect date of birth, how you don't collect their names. And there are things that you very specifically do. This has been laid out by HHS many years ago.
Sure.
Right? So what we did, the other thing we do is EMR and EHRs, basically the way they were built, EMRs were, if you go back and look at the history, they were built to just, for one organization. Then they went to EHRs, like multiple organizations getting connected. So now, recently, the FHIR technology that Office of National Coordinator put out, that is what we're leveraging. So for what we did for primary health care was set out a FHIR standard, their version 2.0 came out last year, where we tell how we will collect this data and what we will collect. It's all specified, it's all laid out. You can just go to FHIR.org and look that up. It's a UDS plus thing. So basically, when you collect it, you don't have any patient identifiable, but you have enough information that when you collect over time, you can take some actions, like are the diabetic trend at a certain area, certain geography going up or down, right? Or is it impacting a rural area more? There are differences in geography, there is differences in age group, there's differences in gender, and there's differences in outcomes. So you can start seeing those things once you collect data at that level and analyze data at that level. So that's what we're doing. That's just one example. I can give you more, but I'll pause for Barbara to.
I mean, there's so many things that I want to follow up on there, but two things stick out to me immediately, Barb. Data and the sheer volume of it. Yeah. Also, like in those modernization efforts, it seems like a lot of what HRSA is leaning into, along with other health organizations, is interoperability. Am I reading those right?
You are. And there's so many things that, Maximus does as well. And so when we are looking at modernizing the systems, which is what you're trying to do with how you're looking at the data and using the standards. So that's really one of the key pieces, is following the standards that are set so that you can get the interoperability. So that's beautiful. And that and the HL7 standards, which are more tried and true. So a little bit about the standard is that HL7 standard is really about more of the administrative data, and FHIR standards is more about the actual clinical data. So now with the combination of those in the new systems, that is really what we're looking for. And then we go a step further, in which we have FedRAMP services. And so once it's FedRAMP, you have that security kind of guaranteed. So those three pieces are a big part of how we can actually modernize these systems, which is, it's so difficult. Some of them, when we talk about modernization, I think we're really looking at trying to, system transformations is really the word. And so what happens when you're doing that, we follow basically 4 principles. And I call it rush. So first the R is really, some might say it's reliability, but I would say it's redundancy, that some of the systems that we've been building just have no redundancy in them. And that's a big part of what we're doing, and also brings in other innovations. So you have redundancy, you have user access, and you're trying to get user access across people who aren't super users. Like, how do you bring them into your models? And then S is standards. So that's the big part of it. That's what we look at as well, and as we're trying to modernize. And then the last is H, would be human-centered design. And that's where we're really focused, the human, the patient. That, we're really tracking and resonating, because we're finding those same things and trying to focus on the principles of what we're doing, so that anybody who's doing modernization are following these. And then you're always checking, are we completing these? Are we getting these into our systems? Yeah.
Srinivas, one thing that you mentioned, I want to tease out a bit. You talked a fair amount about PII, personally identifiable information, or in your case, PHI, health information is my assumption. I'm not the expert that you are.
Yes.
Experimentation needs to happen if these systems are going to be modernized long term. And based on the sensitive nature of PII or PHI, how do you push that particular envelope in an organization as big, as diverse as HRSA, with such an important mission? How do you experiment? How do you sandbox those issues while safeguarding data and innovating at the same time?
Right. So it's an excellent question. So basically, the way you got to think about it is, you go by principles. First, we always ask the question, do I need to collect the PII and a PHI? If I don't need to collect it, I don't collect it. If it is required, then that's the second part of the question comes up. Okay, now I have to protect it. Thankfully, NIST and all, there are a lot of standards out there already published that how to protect specific types of data. What controls you need to have in place, it all predetermined. It's a checkbox and things that you do. So when we are collecting, so what we're doing is when we build new systems and things like that, we're just now cloud native. Whether it's provider hyperscaler A or hyperscaler B, they all have now what's called a governance structure, which basically sets up automatically what policy applies based on what type of data you collect. It's governance policies by design, it sits on top. Then there is what's called a landing zone, where the infrastructure is built with all the controls in place, like how the network is set up and all that. So once you have that, you can add any subscription or any accounts underneath it and apply those controls right out of the box. So when you are playing in a, let's say, a sandbox type of situation where you're just playing with synthetic data, that's the other thing we do, is it's not real data, but it's data to make look real, so you can play with it and see how the system would perform, right? So those types of things we allow in dev environment and sandbox environment without controls, because sometimes to see how a certain piece of technology works, like if you're applying like an AI or large language model on top of something, does it pick up the name? Does it pick up things correctly? So you have to have real data sometimes just to play with it. So then you use fake data, which looks like real, but you test it before you put any real data. And real data is only put in production. So there's HHS and everybody has policies in place. So when you have real data, then you protect it a certain way, you apply certain levels of encryption and all that. And with PII and PHI, now we're looking at, if you have a high value asset and you collect that type of data, you really need to move to post-quantum encryption technologies and things like that, where your encryption level is going to be higher and higher and better, and how you access those things are different and things like that.
Srinivas anticipated where I was hoping to go next, Barb. He mentioned LLMs, generative AI. A lot of organizations are trying to tap that amazing potential there to scale, to replicate elements for their organizations, improve operational efficiency. Take me down that particular journey. Once you've successfully sandboxed, you've sort of ensured that PII or PHI is safeguarded, what are the next few steps that you have to sort of go through those paces in order to tap Gen AI's potential?
Yeah, so I would say it's really, you have to look at it in almost 3 tiers now. So what's happening is that And it's happening now, which is you're having AI working in, for any kind of administrative kind of tasks. It's assisting. We have an AI generated tool that does triage, and basically it's a 90% accuracy rate. But at the same time, we would not put that out on its own. So the first things are really administrative pieces of like how you can assist the actual doctors to do work that they're doing. So it takes them less time to do something. So that's something that can be done. Then the second tier really comes in is the pilots, which is what you're talking about, is that so these things that we want to investigate more, then we might put that into a sandbox where like exploring what they're doing, but not necessarily having real data there yet. The third is the generative AI, which it's, where it is at this point is that it's still very experimental. So for the most part, in large systems, you're not going to let generative AI out and loose and doing its own, work, because we just don't know enough yet and like what is actually doing. So that's the experimental stage, which needs to be done at the same time, but it's that third part of it. So AI is happening now, but it has to be done in ways that are that can be kept in the boundaries. Yeah.
Sure.
So I can give you a couple of examples where, so Barb's really right, it's the levels of it. Administrative, it's pretty good at that part of it right now. You can use it out of the box, right? So the other thing it also is pretty good at is document processing. So what we're doing is we are leveraging that actually right now. So one of our applications, like if you get cases with medical records, let's say injury compensation, it's one of the programs, right? So where you get large volumes of data, applications, and somebody's got to process it and put it in the right buckets. Okay, this is a lab data. This is their health record. These are different things. So LLMs are very good at that. They're very good at reading the language and classifying them, putting them in the right bucket. So when a reviewer comes in, all that sorting is done, versus that would, in the past, would require a human to sort those documents. And basically, you can compress the case review timelines by automating some of these things, right? So those kind of things, we're already trying it out. So that we're not stopping there. So the part that Barb mentioned about language generation. So language generation is chatbot. So if you think of how the technology works, it's basically a next token prediction, next word phrase prediction, right? Sometimes it will hallucinate depending on what your context window is and depending on what you're looking at and attention or what the blocks are and all that, right? So those are a little bit hard to control. So when people are experimenting with things like chatbot, when you're having a live exchange, the controls are a little bit harder to set because you could get a really bad advice depending on how you ask the question, right? And no two models are the same. So what part then you have to basically, the approach there is, what most people are doing is ground it with RAG architecture, which is basically stick it to known documents and say, hey, AI, don't go beyond citing these documents. Don't say a word outside of that, right? That limits in some way, but it protects in another way, right? So there are things that we're trying. So we can do chatbots for help desk type of things, right? Because it's just reading a knowledge base and spitting out some answer, right? The answer may not be perfect, but gets you faster than waiting on a phone call for somebody to answer that because the answers already exists. So things like that. So Gen AI will have uses. I mean, I think it is going to be very, how should I say, disrupting. And if you've not seen it already, it will disrupt more and more things. It's just, what is the next thing and when? It's not a question of it won't, it will.
I love that Srinivas led us down this
Into
case study particular path too,
that was perfect,
because it pulls us a bit out of the ether. We're not talking philosophy anymore. We're talking about mission execution. And one area that I know your colleagues over at Maximus are doing work relative to that is the supply chain, drug inventories. Could you talk about the advancements there in health information technology and what they're going to allow organizations to do now that they weren't able to do before?
There's a couple of different pieces to it, but one of the pieces from like a CMS aspect of it is that, and just to follow on with what you were saying, is that it used to take, a week to process some of the claims, and now they can do 700 of the claims in a day.
Wow.
So that's, what you're starting to get into with using AI. I mean, it's very, even at that administrative level. So now if you're looking at pharmaceuticals, so part of the issue isn't that, not necessarily that AI is going to help immediately, but what it will start to help with is tracking where the drugs are, where we have shortages, because our biggest issue in the States right now is that 90% of the scripts are generic drugs, and we have a shortage in almost all of the generic drugs, and most of the manufacturing is done overseas. So that became very apparent during COVID. And so now we're really working on those kinds of pieces to put that together. So we're working on some things right now in order to make that happen across the country.
One area I want to be sure to hit, and it still follows this case study track that we're talking about here, Srinivas, is HRSA's push into telehealth. Talk a bit about what you're doing in telehealth and how it impacts the technological work that you and your colleagues in the CIO shop are trying to bring about right now.
Telehealth was already well known for, if you were trying to do behavioral health type of things. There are certain things where, you're just face to face and you're just talking, right? Those are already to do. You sometimes need initial triaging. So what that grant did was it set up 2 centers at national level and 12 at the statewide levels, so that at different locations where you could get triage much, much faster before you got to hospital. So I think telehealth will continue to grow, and in certain areas it's going to grow a lot more. When it comes to rural health, the issue becomes the access point. Right. So if you don't have a good access point, so either you have to establish a physical access point or you have to establish a virtual access point. And virtual access point is always faster and quicker and better. So HRSA was also working with other agencies to put out grants where you have to have broadband in some of these areas so that this audio-visual experience is actually normal versus, if you're looking at old dial-up lines and things like that, that'll work quite well, right? Overall, I would say telehealth is only going to grow. It's just some specialties will grow much, much faster. Example, behavioral health, and certain specialties. And if you look at the new MAHA agenda, where you think about nutrition and, that kind of counseling can be done much quicker with telehealth, right? So there are things that you can do with telehealth and technology now that you probably couldn't do a few years back. It's just the adoption, it's just putting it in the right place, putting it in the right flavor is what's going to make it go faster.
And thank you for watching The Federal Focus Health IT. If you like this series and want a deep dive on other topics critical to the business of government, go to our website, fedgovtoday.com, or the FedGov Today YouTube channel. You'll see episode 2 of The Federal Focus, Contact Center Modernization, on April 28th. For FedGov Today, I'm Francis Rose. Thanks for watching. Good night.